I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome to the Love and Science podcast. I am so honored to have an amazing guest today. Her name is Dr. Brittany Panico. She is a friend, she is a colleague, she is a rheumatologist. She's a fantastic person, and I'm so excited because there's so much we don't understand about rheumatology and infertility and recurrent loss and the overlap. And today, hopefully, we're going to shed some light on those topics. So just by way of introduction, Dr. Brittany Panico is a board-certified rheumatologist. She is the chief of rheumatology at Summit Rheumatology, where she has offices in Arizona, Colorado, and Oklahoma. You all know I travel between 2 states, and to travel between 3 states, I do not know how she does it, but she does with grace, and she always looks fabulous. And, she's a gout specialist too. So I remember like 2 seconds in med school learning about gout. And, I didn't quite realize or appreciate how much it affects people's quality of life and really is present, not just for men, but women too. And so I'd love to talk about that today as well, just to kind of remind us that this exists. And if that is you, that Dr. Panico is here to help. So welcome, Dr. Panico. So lovely to have you.
Thank you. I'm so excited to be here.
Yeah, absolutely. So, I'd love to start by talking a little bit about sort of what you see in your practice in terms of, people who've come to you with infertility, who also have rheumatological disease. Like what is your approach to that sort of a patient?
That's a great question. And I think it really depends on what the big picture of what's going on is. So one of the first things that we think about in rheumatology is identifying if you have something that is an autoimmune diagnosis. So a lot of times people think that rheumatologists will treat Hashimoto's. And I think that's kind of a whole another story for a different day. But we're not the endocrine specialists. So we are the immune system specialists when your immune system is essentially reacting against your body. And although you can say that about Hashimoto's, we're not that kind of specialist. But we identify things like lupus, rheumatoid arthritis, psoriatic arthritis. There's a lot of different other diagnoses thrown in there. And one of the more pressing ones that we look for when we think about women who have either recurrent loss or are struggling to actually conceive is something called antiphospholipid antibody syndrome. And that's a syndrome where your immune system actually makes it more possible for you to develop blood clotting. And you can have bleeding and blood clotting happening simultaneously together. And so it can result in essentially decreased blood flow to the developing placenta. And so we can kind of go into details of that, but we do testing and really take a very detailed history about things that may be part of your family history, things that you may be subtle symptoms that you might not necessarily relate to the fertility process, but actually mean quite a bit in terms of developing a diagnosis or understanding why it may be difficult to go through that process.
Yeah, and I'm so glad you brought up APLS. Like I have diagnosed so many people with it in my career, and it's like amazing. People come with so many losses, and and it's like why? Or maybe they've had a live birth and then they just keep miscarrying over and over again. It's like this was so quote unquote easy the first time, and now it's happening. And that is one of the things that we can actually act on, right? We can prescribe anticoagulation, baby aspirin, Lovenox, and really get somebody through a pregnancy. I find sometimes it's because I think the diagnosis of APLS is so stringent, right? You need like 2 sets of labs over 12 weeks. And so many of my patients and clients don't want to wait that 3 months to kind of find out. We're often in this gray zone of like, and what if the antibodies are intermediate? What if you don't get the slam dunk diagnosis, but you think somebody's on the spectrum? I think every situation needs to be handled kind of as an individual situation in the context of somebody's life. Have I treated somebody before 12 weeks when they just felt so anxious about moving forward? I have. I think it's really, really important also to realize that we now believe, and we have data to show, that recurrent implantation failure, which is a phenomenon of IVF where people are just having embryo after embryo transferred, and they're not implanting, that can also be related to APLS too. So I was always taught like, oh, it's after the pregnancy has been established and people are having these, often later losses, and you have to think about it. But now, as the science evolves, we now know that even at the point of getting the uterine lining to a place where it's a fertile ground for an embryo, even APLS can affect that too. So I think it's really important to have that high on the differential and to do the testing when appropriate. Yeah.
Exactly. Yeah.
Yeah.
And there's
So
different
yeah.
factors, right? Like you mentioned the inability to implant. Anytime you're asking blood vessels to grow, right, you need the right things to happen in the body.
Yeah.
And you also we kind of think about it as like, well, my body should know how to do this, right? And
Right.
to a certain extent, if your immune system is prohibiting or blocking that process from happening, then your body's not getting the right signals for that process to move forward. And so you mentioned, science and data, and there's a lot of science that we don't understand during the pregnancy phase or pre-pregnancy phase for women with autoimmune conditions, because part of it is we don't have that population to actually study from. It's very difficult to perform, scientific studies. And the question is, we have a handful of medications that are safe. And so there's not really new drugs being developed showing benefit in pregnant females. I think one of my biggest sort of areas of angst in rheumatology is we have a very limited number of medications that are studied to be safe. And we have data from mother to baby, and there's a database that shows us, where we can pull that information from. But the new drugs that are coming on the market and being approved are not showing safety during pregnancy. And so it's sort of like area of frustration where it's like, we know there's a growing need for safety information during, trying to conceive, being safe during pregnancy, safe after pregnancy. And it's just kind of one of those things where, we need the science to be there. I'm glad you brought that up.
Yeah, no, absolutely. I think just there's so many unanswered questions in the field. And if you are somebody who's struggling and really has, a tough rheumatological disease, I think it can be really hard to know. It's like, what's the best of the bad choices, sometimes is like, what do you do? One thing I wanted to ask you about, and I have a rheumatologist colleague who's also gone through infertility, who obviously she has kind of a special interest in this area. And she says that like lupus in and of itself has just been, she's noticed a lot of infertility in people with lupus. And I have too, but I don't have a patient population that's like entirely people with lupus. And, I was always taught, oh, it's a cyclophosphamide, and they're, sort of given such gonadotoxic therapies to control the lupus. We do inpatient consults all the time on people with a new diagnosis, even children, right? With pediatric lupus about fertility preservation. But, there also seems to be something about people with lupus that before they even get, an agent, that their anti-Mullerian hormone is lower than you would expect for your age. And we also see this with other rheumatological conditions. And so, is there something sort of like, inflammatory that's going on in the system? Are there anti-ovarian antibodies as well? Because there's this sort of autoimmune phenomenon, and we know that autoimmune diseases tend to run together. Like, what do you think is going on for these people who, have rheumatological diseases? Maybe they even haven't gotten agents yet that we know are harmful, but we're already seeing, and we know AMH is not a fertility test per se, but there's something going on with their egg reserve that may affect, future outcomes.
Yeah, I love that question, and I wish I had, a bulletproof answer about that. But I do see, and this is really in all stages of autoimmunity, is that, and the way I describe it to my patients is, your immune system is like a factory. It's designed to make and differentiate types of white blood cells to essentially fight infection in our body. But during the autoimmune process, what happens is that factory setting, right, that's set at a threshold and then elevates when you have an infection, is set at a threshold that's higher, creating a lot of energy or needing a lot of energy to produce these cells. And that energy then is turned around and focused inside your body. So instead of outwardly trying to fight an infection, you're essentially using your own energy reserves to target your own body. And so that caloric essentially intake or the need for that drive to happen overrides basic bodily things, meaning we see a lot of hair loss in people who have autoimmune syndromes because you turn off signals to allow your hair to grow when you're using that energy. We see weight changes either up or down because you change, your caloric, your metabolism changes. And so there's all these things that are using energy in your body to essentially target itself. And so that energy that would otherwise be devoted to other things, right, is put aside or told it's not as important. So oftentimes menstrual cycles will change and be really off if you're somebody who's been very regular. A lot of things can change in terms of like how much bleeding you have during those cycles, your energy, fatigue and those kind of things, the way that your mental functioning, we talk a lot about brain fog and fatigue and autoimmunity. And so I really do think that there's this reserve that is otherwise devoted towards our reproductive cycle, that when there's inflammation inside of your body says, that's not important to me right now. That's not something that I'm going to focus on. And therefore, it sort of puts it in the closet a little bit or puts it somewhere where it's not as at the forefront, even though mentally, right, we have our own agenda for our lives. We want other things to happen. And so, we're trying to override those signals. And a lot of it has to do with, again, when we talk about medication, are we using something that is not intended necessarily to, I guess, harness those energy reserves? So we can use things like, I'm just going to use prednisone as my basic example, because prednisone we use a lot of times to calm inflammation down. But prednisone doesn't necessarily change the course of the disorder that's going on underneath the surface. So it just sort of puts a blanket on top of the inflammation. So it's not really solving any issue underneath the surface. And so a lot of times we think about using steroids for inflammation and controlling it, and then people start to feel better. And then there's not a next phase. So in rheumatology, our next step is always to find, okay, what can we do that acts a little bit like prednisone, but actually does more to treat the underlying issue. And so if we just give sort of surface level medications of like, this is going to work for now, and we're not actually treating that underlying inflammatory signaling, we're essentially putting cloud over things and ignoring those signals that are really driving the force to happen. So I'm not necessarily saying that a lot of people are undertreated, but I do think there's a phase of autoimmunity, especially in the beginning, or especially when women say to their physician team or their medical team, I would like to start trying to conceive, is we do what we feel like is safe and kind of what we know has been safe in the past. And so a lot of patients get converted to some version of steroid for a little while. And without us really understanding, that's not doing anyone any favors, even though it's quote unquote safe. So I think there's sort of this misunderstanding about, if we're not actually controlling the driving force of why that inflammation is happening, then we're not allowing your body to recognize the signals. It's okay that I devote energy towards these other things. It's okay now that I can, move forward with, again, making sure my uterus is a habitable place, making sure the mucus is in it, all those things that have to be exactly in line for fertility. And so I think, the best that we can in rheumatology, we try to work with, again, what's safe. But at the underside of that, we also have to recognize if the disease is still going on, that process may not happen in alignment with mentally what we're looking for.
That's so fascinating, really, really fascinating. And, I've actually never heard anybody describe it quite like that. We think about that in terms of like hypothalamic amenorrhea, that the body's just shunting energy towards like the necessary organs. But I had never thought about kind of how that sort of disease process is sort of taking the energy. Sure, I've thought about it in like cancer, but not rheumatological disease. And that makes so much sense for what we see. And also, I talk about luteal phase defect like this as well. Like, sure, I can give you progesterone, but that's like a band-aid on the problem. Like, let's correct the problem at the source so that you could actually have a good ovulation. And then, we're going to move on forward. And so it just makes so much sense. And thank you for such a clear explanation, because I think it's going to resonate with a lot of people. And now I have so many thoughts, but like one thought I want to say is, what if someone comes to see me in my clinic with infertility and they actually have a rheumatological, like I always take a full review of systems. Like, what if they tell me they have like joint aches and joint pains and, and they've never really maybe, so many people don't even have a PCP. Like, at what point do you start to think about saying, I wonder if, there's some sort of chronic disease element going on here, right? Because we have so much unexplained infertility. A third of patients have unexplained infertility, which I just think is like undiagnosed, right? So undiagnosed infertility.
Exactly. Yeah. So I think the first place to start is, I mean, the easiest things to look at is sedimentation rate. We call that ESR and C-reactive protein. So if those are elevated, right, there's some inflammatory process happening. However, on the other side of that, patients with psoriatic arthritis or like psoriasis, for example, may not have elevated inflammation levels. So it gets a little bit tricky to rely on those specifically to help with the diagnosis. But I do think there's a component of, establishing too, if you're complaining of a lot of joint symptoms, or you have rashes, or you have something that just these symptoms that you can't explain, to see a rheumatologist. And specifically, and I don't mean this in, a biased way, but I do think there's something about women helping women where we have a little bit of a different perspective of the urgency or the fertility / infertility arena, right? And so I do find in rheumatology, there's sort of this, I guess, traditional approach of women being heard or being told that they can't try to conceive and fix their underlying issue at the same time. And that's just not true.
Right.
We have medications that are safe. We have medications that have been proven to not lead to, increased risk of birth defects and things like that. And so working with, a team of people who are comfortable with using those medications is really recommended. And there's, we can do, again, nothing happens overnight, right? But we can do things that sort of speed up the process. And even something like hydroxychloroquine. I know it's in the news a lot. I know, COVID, people think, oh, well, that's just the thing, that was popular during COVID. There's a lot of role for that during sort of the fertility workup, because it's an anti-inflammatory in a way that modifies underlying disease. So we call that disease modifying agent. And it's very simple. It's, there's very few side effects. It may not be something that somebody takes long term. I have plenty of patients who say, I'm going through this process, working with, their female healthcare team, and we opt to use it just for a short period of time, just to see if the body, the inflammation responds or calms down. So I think sometimes there's this idea of like, I have to be on as minimal things as possible, which I completely agree. But when we can't answer the question, when we know there's some inflammatory thing happening, and maybe our labs don't show that, or maybe we just can't put a name to it with a blood test. I do think though, as long as somebody has the time, maybe say 1 to 3 months, of just seeing if that helps. Because again, it's a safe medication. Our lupus patients, rely on it. And so if we can calm that inflammatory process down, there may be something to it that we just haven't found yet to put into words or put a name to, that sort of, again, takes that inflammation, all of that metabolic energy triggering inflammation, and calms that down in a way that prednisone can't. So again, it's not to say, well, because I think that's kind of been our approach, is like, here's a little bit of prednisone. We know we can kind of get by with this, but that may get you to step A or B, but it might not carry you through C, D, and down the line.
Yeah. Yeah. And that makes so much sense. There are actually some prelim data. I used to actually give, not so much anymore. And I guess I changed practices and sort of stopped. I need to revisit that, but I used to give Plaquenil or hydroxychloroquine to patients with recurrent loss. And, some of the preliminary data actually was encouraging in that population. So it's just interesting to think about. Yeah. Thank you for sharing that. Another question I had, as you were talking about sort of these rheumatological processes and maybe stealing energy from fertility, these are chronic diseases, right? There's different phases, but there's something that you don't really undiagnose somebody with these things. And, one question I have is now we have the possibility for fertility preservation, right? And, yes, certainly for girls who are about to get, toxic agents and such, but also even for like, young adults, right? Who are, they've gone through puberty, right? But maybe their egg reserve is lower than we might think. Under different circumstances, if they didn't have these diseases, it would be higher. We just don't know. So one thought that I have is like maybe thinking about sort of opening up the communication a little bit better between fertility specialists and rheumatologists about, okay, it only takes 2 weeks to do a cycle of egg freezing or embryo freezing. And, if we know that these things can be progressive, like, could there be a role for more fertility preservation? Obviously with shared fertility decision-making, but if fertility is a priority for people and we know it gets worse with time, maybe that's something to sort of open up the conversation a little bit more.
Yeah, I love that. And I think
Yeah.
really it is just about opening the conversation, right? It's joining together to say, I do these kind of things and I can offer these kind of services. If you have anybody who, fits this description, let's work together. And I do think as we're talking about this, it like sparks so many ideas that I have, because you're right. We see people of all age spectrums, right, who may not even be thinking about it. And we typically ask in rheumatology, I make a point to ask, are you trying to conceive, or is your goal to have, to try to conceive within the next, I usually say 6 to 12 months, because that gives me an idea, okay, if this doesn't work today, what's going to be my next step and what am I thinking about?
Mm-hmm.
And I do think having that, at least, you know, coordinating relationship where we can say, I've worked with, somebody in town who does this. Would you like a consultation at least to understand what your options are? Because you're right.
Absolutely.
Sometimes we get to a point in our life where it's like, I wish I would have thought about that, but nobody explained to me what my options were, right? And it's
Yeah.
sometimes it can be so heartbreaking, especially, and I hear a lot of times, women will come with a diagnosis and they'll say, well, I can't try to conceive. And it's like, but explain to me why. Well, I was told through this journey, right, that these medications make it so that I can't. And aside from cyclophosphamide and repetitive doses of it, so typically one cycle we think, doesn't significantly limit your ovarian reserve. But again, we don't know because we're not always testing every single person prior to using it. But not necessarily, there's not a ginormous population of patients that require that medication.
Right.
So I do think just having that as a, would you like to explore what your options are with somebody who understands that conversation?
Absolutely. We've done a lot better in the oncology world, I think, and, people are already getting blood work, right? So I think in both directions, right? Like when I see a patient, I'm like, oh, maybe they have rheumatological disease. I can add on a stud, right? Because we're already getting 5 vials of blood, right? Like same thing with rheumatologists, like an anti-Mullerian hormone, it's very controversial in our field because a lot of people say it is not a screening test for fertility. You can conceive with an undetectable AMH. Absolutely. But I think that sometimes trending it over time, once the AMH is undetectable, there's data that menopause happens in like 5 to 6 years. And if you're 22 with an undetectable AMH, then that, you might want to know about that. So I think that just, some rheumatologists might say, oh, I don't know how to interpret it. Like if it's less than 1, not so great. If it's above 1, better. But also kind of looking at it sort of age related. Like if you're 22 and have an AMH of 1, that's very different than if you're 39 and have an AMH of 1 too, because that would be expected at 39, but not at 22. So, maybe there's even more like, oh, your AMH is 0.6 and you're 25. You already asked the question, which I think is amazing. But then pairing that to say, that's how I counsel people when they come to see me. There may be more, I put urgency in air quotes, but, sort of a little bit more motivation to consider fertility preservation when we see a low value, and to have a baseline is really helpful because then you can see if they have to go on one of these agents, like how much has it affected things. Sure, there's a natural decline over time, but like to have 2 data points is always better than just, sort of that question mark. What was it before we started? Right. So it's just an
Right.
idea that I had. That's fascinating. What other thoughts are coming to your mind as we're talking? Just so many options for collaborations.
Yeah. I mean, for me, the biggest thing is just never stop asking questions. If you really are curious, I mean, there may be people, you may be in a situation where, we say, I don't know. I'm not really sure
Mm-hmm.
about the answer to that question, but it sparks interest. If patients are asking, it does pull the level of accountability of like, I should probably look into this and find this out for somebody else who asks that question. So I think it's never wrong to ask. And I also think if you come into a situation or come across a situation where you're told, this medication will change your ability to conceive, always clarify that. Because we often will use medications in rheumatology where we're advising patients not to try to conceive when you're on that medication, for example, because it may lead to increased risk of birth defects. Methotrexate is the biggest one that comes to mind. It's a very common medication, and we do not want you trying to actually
No.
you're on it. But just because you're on methotrexate doesn't mean you can't stop it and be transitioned to something that is safe during that phase of your life, and then manage, your condition in a safe way. So I think there is sort of this idea of, well, I'm on this and my doctor hasn't offered to switch me onto something else. Therefore, I don't want to rock the boat, or they're telling me this is what they think I need. But we oftentimes don't understand or don't ask or don't know what people's goals are, right? And so
Mm-hmm.
oftentimes we rely on the patient to say, you know, I am actually thinking about trying to conceive, or I'm meeting with, a fertility specialist in the next amount of time. How might my treatment change if we go down that road? And often, now I really encourage patients to use ChatGPT. If you're nervous about asking your doctor a question or your healthcare team a question, put that in ChatGPT and you can actually bring something with you to say, I don't really know how to ask this question, but this is what I'm thinking about, and this is what I found on the internet. Because then we're forced to answer to that, right? And I think if people get upset or get annoyed that people are asking questions, they're not the right healthcare team for you. We want to align with your goals as a patient. And it really is about what you want for your body. And I think we don't take that into account as much probably as we should in healthcare. And especially with autoimmunity, because there's such a wide range of medications, really making sure that your goals align with what your healthcare team is, expressing as quote unquote necessary or recommended, right? Because we can always change treatment. We can always do something else. I've had patients who, say they're trying to conceive for years, and we keep them on medications that are safe and we make it work. I have
Mm-hmm.
patients that go, from pregnancy, breastfeeding to, trying to conceive again right away. And
Mm-hmm.
we just have to have that conversation of, okay, what's happening inside your body? What are the changes happening? And how is your autoimmune condition? What do we think it's very active? Do we think it's controlled? Especially
Mm-hmm.
with lupus, we brought up lupus. Trying to conceive during a phase where your lupus is very active is going to be significantly challenging because,
Right.
again, your body is using a lot of energy to create that inflammation. And so we want to set things up for the best possible results, but that may require a little bit of time to get your diagnosis under better control.
Yeah. And that makes so much sense. I think maybe some doctors don't ask, some patients don't say. I also wanted to bring up, I think there's a lot of women, especially in their 30s, who are like, maybe I want a family, maybe I don't, I'm not really sure, sort of, I think with like the advent of birth control, and everything, I think there's just a lot more ambivalence that I see about family building. And so I might even extend that. So if you're in that gray zone of like not being sure, I would still bring it up and just say, hey, I've been thinking about this and I heard this podcast or, and I think I might want to conceive if I were to shift gears and that was my reality. How might my treatment be different? Right. Cause that is its own sort of, it's not like I've been trying for 6 months or 12 months and it's not working. It's like, what could the landscape look like, which I just think opens up so much possibility for decision making.
Yeah, especially if you're somebody, with your rheumatology team where you're on a 3-month cycle or 6-month cycle, right, with your medication, we want to be able to make those adjustments with you. And so it is really important to bring that up of, even if you're thinking about it to
Yeah.
to consider.
And that's also a great population of people who might benefit from fertility preservation too. Maybe now is not the time, but I mean, gosh, we saw this with COVID. 5 years go by and you go from being 32 to 37 and things aren't as easy and people kick themselves. I see so much regret. I have podcasts about regret. And so, if there's even that like sort of glimmer, that sort of inkling in your mind, just sort of just lean into it and think about it, because it's always easier sort of on the front end than on the back end, I would say, from my experience. Yeah.
Yeah. And if things, if you change medication and your body doesn't feel as good, it's not a defeat like, okay, this is never going to work again. It just may not be the right time. And that's a conversation of, okay, well, what are some of the other things that we can do to maybe help this be in more alignment? I think sometimes we have to get, open our minds to adding medications that we may not pair together all the time automatically. But again, in the situation where somebody's, wanting to conceive, we have to think about that. And so you may go from being on one medication to now maybe needing two, but those two are much safer for you if you make that decision. And that's okay. It doesn't mean that things are worse. It doesn't mean that you've failed. It doesn't mean that your body, is failing you. It just means that we have to be, I use the term kind of creative in a sense of we have to open our minds to what might work for an individual, even though something else was working before. And
That's
it's
right.
okay to revisit, multiple times if needed.
That's so beautiful. My coach brain is like, this is possibility thinking at its finest,
Yes.
right? Like being creative, thinking outside the box. Um, Dr. Panico, you were a gout specialist, and I, about in the last year, saw my first patient with infertility and gout. And so that was really interesting for me because I kind of had forgotten that those two can coexist. Can you share maybe a minute or two just about, what's new in the gout space? What if you have infertility or you're trying to conceive and you do have gout? Like what's going on there? Because I can't think of anybody who has their finger on the pulse. Is that the right expression? Yes. Kind of knowing what's up with gout right now.
That's a great question. You're putting me on the spot about medications as we're talking about that. So yes, it's certainly possible. Women of any age can have gout, especially if you have a family history. It's a metabolic disorder, so it does not mean that you're eating bad foods. It doesn't mean you're making, bad lifestyle choices. It really has to do with your body's ability to filter out uric acid through your kidneys. And let's say maybe you're a transplant patient, right? You've had a transplant and you develop gout because of the medications caught, effects on your body. And so I'd have to go back and double check, medications, but I definitely, it's certainly possible to treat you through that process and, working through fertility and also understanding that, that it's certainly possible. I do think there's sort of this idea, and I'm working so hard to bust the myth that women, especially premenopausal women, can have gout. I have patients who are in their 30s, and have had gout before. And so it certainly is possible. And also, it goes back to that inflammation, right? If there's inflammation going on in your body, that's not the ideal host to try to, heart to to have a pregnancy. And so we want to make sure we get that inflammation that gout can trigger under better
Sure.
control so that your body does have the energy reserves and, can sustain a pregnancy to term. And so I think there's ways to find gout specialists in your area. Google is a great resource. Again, Chat GPT is a great resource. But I think certainly, young women can have gout, and I'm so glad you brought it up because it's definitely out there, and I think, misunderstood and misdiagnosed, and a lot of patients are treated as rheumatoid arthritis or seronegative arthritis, right?
Mhm.
And they actually have gout. So if your medication isn't working, then consider gout as a diagnosis even.
Yeah, all I remember is that there was a medication she was on and there was a way through. And so again,
Yes.
possibility thinking. I think we just have to like think about it more broadly and know that there are
Absolutely.
ways through. So that's a great segue. I wanted to just sort of have you have a platform to share. Where can people find you? I think your approach to rheumatology is very novel. I think your fund of knowledge is so deep, and your experience is, obviously spans many years. And as we've heard today, your perspective being very holistic and goal oriented and patient centered. I think we need more of this in the space. And so I'm sure people are like, where can I find her? So please share, where can people find you?
Yes, so I'm at Summit Rheumatology. I have a wonderful team. And so my main location is in Arizona, but I have practices in Colorado, Oklahoma. And then I'm at Dr. Brittany Panico on Facebook and Instagram as well. So DR and my name, Brittany. Yeah.
Yes. Follow her, please. And thank you so much for sharing your wisdom. I know so many are going to benefit. And until the next time.
Yeah, thank you for having me.
Absolutely. Bye. Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.